So I guess I'll start with Dr. McKee, and if you all will just, they're going to take 4 or 5 minutes, short. They're going to share their thoughts, and then most importantly, when they're done, we're going to open this up and ask for you to share your ideas, ask your questions. That'll be the most powerful.
It was over there before.
We'll do that. So, Kathy, you good to go?
I think so. Can you hear me? No?
Might have to on the side of the mic, on the right, what side? Sorry.
Massaging the mic. Oh, this little thing.
Yeah, let me get all these turned on for you guys.
Oh, okay. Okay, I think we're ready. Oh, there, hear me. First of all, I want to say to Mr. Quinones how much his book has meant to me. I became a doctor in 1980. This is kind of like my life. Reading through my life as a physician, and I've practiced in a number of different practice settings, both here and in Springfield, Ohio, and lived through the beginning part as a resident, learning how to prescribe very carefully, minimally with narcotics, living through the pain as the fifth vital sign, being marketed by the Purdue Pharma rep for OxyContin, and wondering what is going on. Does that even seem plausible? Working for the Bureau of Workers' Compensation in occupational health centers, where I dealt with people in chronic pain and disability, and seeing how things were not covered as far as biofeedback or counseling or acupuncture or physical therapy, as much as just being able to prescribe these strong opioids, and now the swing back. It was remarkable how he could cover such a complicated issue so clearly and extremely accurately.
Thank you.
And I appreciate that. I also have family in Mexico, but I don't know really anything about that side of things. So as a physician now in student health, and there again I worked at the university in Springfield, Ohio, Wittenberg University for a short while, as well as here at the Ohio State University. I think we're finding ourselves behind in recognizing and providing the proper support and treatment for students who have been dealing with opiate addiction and now recovery. We are trying to catch up. A university as big as Ohio State also has many different operations going on at any one time. For instance, the Generation RX that Dr. Hale is involved in, I knew nothing about until being invited to be a part of this panel. The wellness program does a lot of educating and screening. I do work closely with Sarah, the collegiate recovery community, but we could do a better job at our university, I think, at working together and informing each other about what is available. I am concerned that students are not aware that there are places to come for help on campus, and maybe part of it is the large size and the fractionation of services. But I think we'll work harder to establish that. It came to our attention a couple of years ago as the CRC opened up their recovery living opportunity, that there were some students on campus who were being prescribed Suboxone from home, who needed to find community resources for the continuation of their medication. On campus, there was no opportunity for them to be prescribed Suboxone. So we have actually spent almost 2 years now fleshing out policy and protocols and monthly meetings, and are now ready to accept our first students. So we are kind of advertising. I think people are concerned that we may be overwhelmed. I would be delighted in one sense. I mean, I don't want to, you know, you hate that there would be that much of a need, but we know there is a need statistically, and we know that we are not addressing that need, and I'm really concerned that students are not aware that we're here. We work a lot with alcohol and cannabis, and I think we need to focus more on a lot of the students that we know have opiate problems at this point. We also always, as far as medication-assisted treatment, you know, we talk about Suboxone, but there are all kinds of medications used for treatment. Treating comorbid issues such as, you know, mental health issues or chronic pain, those can go a great distance in helping students to continue in their recovery efforts. Acamprosate, gabapentin, you know, some other medications that can be used for pain that are not an opiate agonist. Naltrexone. One of the issues that we worry about too, though, is prior authorization. Can we get this covered on insurances? Who's going to do all that time on the phone and faxing back and forth in this day and age where student health services all across the country are really limited in their resources, cutting back staff, all of that. It's a lot of resources for maybe a few number of your students in the grand scheme of things. But wrapping around services, you know, you just need that really strong relationship with counseling, recovery, community, meetings on campus, all of that. The medication, I think, is important and will continue to be developed and more important in the future. But that is only a tiny piece of the puzzle, is what I tell students. And the bigger piece of the puzzle is how do I live without even these medications that are to help you in early recovery. Thank you.
Thank you.
Good morning, everybody. Delighted to be back here this morning, and it's hard in some ways to make any stronger points than Sam Quinones has already made on many of the things that I talked to all of you about yesterday. So I will just try to riff off of what you've already heard. I would like to actually reiterate 3 points that you heard from me yesterday if you had heard the plenary talk, and then add one new point that Sam had brought up, and this would be from the perspective of my being a marriage and family therapist. The first point that I wanted to make from yesterday to reiterate is that the most effective efforts that any of you are going to undertake are those that are going to rely on very strong partnerships between your campus and the communities that surround you. And by extension, those collaborations that build on what I've deemed to be already harmonious relationships, town-gown relationships, are going to prove to be the most efficacious. I'm curious, and I want to pick Sam's brain a little bit further afterwards about the role that Shawnee State had played, and maybe we can even talk about that. The book made it seem as if they were certainly there, but to what extent, I'm not sure. Shawnee State, of course, is a very different university than the Ohio State University, for both, I think, for some good reasons in terms of this situation, and also perhaps some limiting reasons as well. The limiting ones would be more about the resources. I think the positives would be they're certainly much more connected to the community just by the very nature of who they serve. I imagine probably 80% of their students come from an 80-mile radius around that university. But again, nevertheless, for all of you thinking about doing work, this is something that demands a partnership between the campus and the community. The second point from yesterday that I would like to bring up again is that I think that it's extremely important to pay attention to leadership. Sam had talked about leadership at the federal level, and what Wall Street tells us and what a previous presidential administration had told us. Think about what the messages are that are coming from your university presidents, and think about what the messages are that are coming from the mayors or the city councils or the city managers of the communities that surround you. And then now think about the, I think, even more important point, which is how well do they work together? because the degree to which those individuals work together is going to be a great forecast. It's a barometer, if you will, of how well you're going to be able to work with your community partners. So I think it's important certainly for the leaders to be behind you, but it's also important for you to be considering how well they work together. The third point that I want to make from yesterday is to really urge you to keep in mind that any and all efforts that you undertake with alcohol or tobacco or other drug issues, it's going to need to be undertaken if you are working with communities with the widest possible spectrum of potential partners. And I said that yesterday. You should be thinking about partnerships with nonprofits, with clergy, and on, right? That it's just extremely important to keep as wide a spectrum as possible open to these issues. But I also think that if you're going to be hitting people with your particular idiosyncratic concerns, right? We want to do something about alcohol use. Expect that your community partners are going to come back at you with a lot of other issues that they're going to want to talk about. And yesterday I raised issues that really are all over the map. For an alcohol and drug professional, right? Like, why would I care about land use issues? Why would I care about the fact that my university doesn't pay taxes and that the community wants to know where revenue is going to come from? But that's going to come up. And so I think to be respectful of that and to recognize that you exist as part of a much larger ecology of issues and concerns, I think that's only going to help your efforts. My new point, again, as a marriage and family therapist, is to urge all of you to consider having family-based prevention and intervention efforts along the way. Sam had mentioned what we've seen, I think, in the last probably 2 decades, which has been the helicopter parent syndrome. And I see that every day. I especially see it when I'm welcoming students to my campus, and I don't know if Ken said this or not, but I'm the dean and director of the Ohio State Mansfield campus, and so I have high touch with these parents as they're dropping off their brand new freshmen, and many of them are actually asking me a question which you might expect given what we're talking about here, which is my kid going to be okay? And in large part, my director of student life expects me to be able to answer the question, yes, they are going to be okay, but that does not mean that you don't still have a very important role to play. And the talks that I've given to parents of those families who are dropping off their brand new sons, their freshmen, the brand new sons and daughters to our campus, what I talk to them about is having to move away from being in the role of direct supervisor to being more of a coach. And that's, when you think about the metaphor of a coach, the sports coach especially, normally the coach is strolling the sidelines, and they have really direct applicability, right? Because they can see what's going on immediately and make corrections. It's a little more difficult to do coaching when there's some geographic distance. But that's good. That's developmentally appropriate. I simply implore you here to be thinking about ways in which you can engage parents and other family members in what you're doing from the very beginning. When you're looking at recruitment efforts, you're having your admissions people who are doing things that are extremely important to get those students on your campus, to when you meet them and they come on your campus for the first time in an orientation, but also when you're doing career development, workforce development efforts as they begin to approach graduation. All along the way, I believe there are places for you to have high touch points with these parents and other family members as you continue on with your prevention and intervention efforts. So, thanks.
So Steve, as we switch to Ariele, yesterday was the first time that I heard you speak. It's a fascinating connection. I love this idea of the metaphor of a high effort and high comfort marital relationship and how that applies to this town-gown relationship makes a whole lot of sense, so thank you. Ariele?
Yes, thank you. Thanks for having me. Can you hear me? Yes. Can you hear me now? Okay. Okay, I'll speak louder. Okay. Thanks again for having me. Yes, I'm with the Health Matters Initiative from the Clinton Foundation. I want to start off first by reiterating some of the feedback and reactions to Sam's book. Dreamland is an incredible work. I really enjoyed reading it. My team read it. We were all very moved. One of the things that I enjoyed most about it was how much it roots this story in personal lives and names and that kind of thing, because as I kind of mentioned earlier, and we heard from the research, that the numbers in prescription drug misuse and abuse overdose may not be as big comparatively to alcohol, but we're talking about people's lives and individuals, and sometimes that gets lost in some of these conversations. At the foundation, I want to just give a brief overview of what we do, because there's sometimes some misconceptions. So we are a global nonprofit, and we're an operating, not a grant-making foundation, so we develop programs, and a lot of what we do is facilitate partnerships and support organizations and institutions in being strategic about their growth and sustainability, all with the mission of helping people live their best lives. And so at the Health Matters Initiative, which is a domestic-focused initiative, my work falls under college campus health and prescription drug misuse, abuse, and overdose prevention, which brings me here. So along the lines of what we've done in naloxone access and why we promote it, again, going back to the personal, our beginning in that work really started with a mandate from President Clinton, who had friends who had unfortunately lost their young people, their college-age children, to overdose in college. And several years ago, before my time with the foundation, as we started to see this being an epidemic, we found that college campuses were an appropriate place to target that epidemic. And one of the things that we've done is work with pharmaceutical companies just to make naloxone more accessible to universities and communities. My work with prescription drugs does extend outside of the college space, but as you so eloquently said, and Sam made the point, that the community surrounding our campuses is really important and critical in those efforts. So we've worked to make naloxone more accessible. You may have heard some of those partnerships. ADAPT donated naloxone to high schools across the country, and now we have another exciting partnership with them where they've opened up their donations to different kinds of organizations, as long as they're educational institutions, nonprofits, or government organizations, to request donations, a one-time experience of Narcan to get that going in different communities and spaces. So that's great. We see the interest. In my work at the foundation in the first year doing our college work, I was in over 80 colleges across the country running our college health program, which in addition to substance abuse also targets some other areas for health improvement on campus. And definitely saw some interest in naloxone as a harm reduction strategy and some questions, but by and large, I felt that a lot of universities were saying, well, I'm not sure if that's really a problem on our campus. Our students don't use heroin. We don't have that problem of addiction, a specific idea of what addiction looks like. And certainly in this next year, and recently, as we know, this is getting a lot more attention, and we're hearing different stories from a lot of schools saying that they definitely do want to employ this as a harm reduction strategy, and that they're having different kinds of conversations about what addiction looks like and what misuse looks like, and how it doesn't necessarily have to be addiction for naloxone to play an important role on campus. So an important part of that work in terms of strategizing with colleges is we want to make naloxone accessible, and it's great to have donations or have schools and institutions be able to buy it at cost, but we find that it's not productive and doesn't lead to sustainability to simply drop a product off if there isn't already an infrastructure there that knows how to deal with it, how to distribute it, who should have it. And so those are the kinds of questions that we're hearing from campuses. We see a lot of schools that have it just with campus security, which is a start. And other schools are saying, well, it seems it's too controversial to maybe have it in the dorms or train RAs with it. Then we have other schools saying, no, that's where it needs to be, because it needs to be easily accessible. And we're seeing some schools with it sitting in the counseling center. And so those conversations continuing to evolve. Part of the college health work is going to schools, encouraging them to build an interdisciplinary team to address health on campus across all areas, depending on what that school wants to do in that program, which is a separate conversation. But if they're addressing substance use and they build an interdisciplinary team on campus, the idea is that team, one, is really a wide representation of people on campus that is composed both of actors that can really enforce policy change and programming and change the culture of health on campus, and also create an environment where we can fight the stigma against substance use and misuse and really create a culture of normalization on campus around some of these issues. So a big part of what we try to do is create that infrastructure along with making the product accessible. Mentioned, yes, definitely continuing to see a great need for education, and that goes back to the community piece. We recently spoke with a police force in one of our communities where the sentiment was still, they are hesitant to use naloxone because they have an idea that when people wake up from an overdose, they're violent and that it's unsafe. They also mentioned this idea that naloxone doesn't help save lives, it perpetuates addiction and other harmful ideas that we've heard from many corners, so that just speaks to the need for more education. And I wanted to come back to something else that you said, Sam, about the antidote to heroin not being naloxone, but being community, and you spoke so much to the importance of community as well. And we recognize that naloxone is only one piece of this effort, that it has to be couched in efforts of prevention and recovery. Absolutely that naloxone saves lives, but it can only be one piece of that. And so what we're working on now as well is trying to figure out how do we empower communities to do this work. And we have some amazing community-based organizations in our network that are great models. I'll just take a moment to let you know that upcoming on September 14th, we are having a conference on that very issue, a town hall that we're going to hold in Little Rock at the Presidential Center around building a community of support and engaging families and community-based organizations and faith-based institutions in a conversation about their role in addressing the epidemic and really considering this from a holistic perspective. So I'll end there.
Thank you, Ariele. It's a pleasure having you here always. We'll switch to Sarah, but I'm making sure we're all on the same page. Maybe this is being way too much of an instructor, but naloxone being an opioid antagonist, it could be used to reverse an opioid or an opiate overdose. So the harm reduction strategy being used there. So Sarah, you want to finish us off?
Yeah. Hello again, Sarah Nerad. I think before I start my remarks, I just want to say that I'm a person in long-term recovery, which means I haven't used drugs or alcohol since August 16th of 2007. So all of this is, thank you. So all of this is something that's really personal to me. I was a student in a collegiate recovery program when I was an undergrad student, and now I work with all of Ohio State students in recovery. So absolutely, community is a solution. That's why our programs are called collegiate recovery communities, that very much resonates with me, and I love that the book and your remarks ended with Portsmouth came together as a community and they recovered together. So often we hear that addiction is a family disease, and so the family needs to recover together. It's the same with all of us in recovery. We need community, we need one another. So I just kind of wanted to start with that. When I think about the work that we're doing here, and I'm really excited that Ohio State hasn't been afraid to talk about this. And in no way does creating a medication-assisted treatment program, a collegiate recovery program, talking about naloxone on your campus, say that you have a drug problem on your campus. No way, that is not what anyone is saying. That's not reality. We just have a bunch of young people. That's what we have here. And some of us aren't going to be able to moderate. Some of us are not able to moderate our drinking and our drug use. We need a program of abstinence, and we need recovery, and we need recovery support services. So that's kind of who we're talking about. And we are everywhere, on campus, in the community, in our jobs, in our churches, wherever. People in recovery, people that need recovery are everywhere. So if you're bumping into kind of that administration saying, well, we don't want it to seem like we have a drug problem, there are a bunch of us in the room that, can help you kind of frame a really good case for that's not what we're saying and that's not what this means. This means we have awesome people here that need a program of recovery. That's what that means. We have to address this in a comprehensive way. We can't have, one piece over here. Otherwise, we're just going to be constantly playing whack-a-mole. One new thing's going to pop up over here. Another issue's going to emerge. We have to address this comprehensively. We need to have the full continuum of care. We need prevention, we need intervention, we need referrals to treatment, and then a referral back to the campus, and then that recovery supports. That is how we support every student, no matter where they are, whether they need recovery, whether they need to cut back, and they're able to do that, or they don't really drink or use at all. They exist too. And it's great to see Ohio State starting to do that, and how quickly we've been able to get some of this stuff rolled out. It's been great to see. So our students in our collegiate recovery program, they fill out an application. We ask them for their drug and alcohol use history. Of those 45 applications, only 2 students just drank alcohol. Only 2. All of our students, and myself included, we're polysubstance users. So I'm really excited about Screen U, because no matter if you take the alcohol one, the marijuana one, or the prescription drug one, we're going to be able to identify you. Because if you're like the average student in my program, you are using all of them. So I'm really excited about that. And again, that's why we need to, when we talk about opioid use disorders and the opioid epidemic, the heroin epidemic, it needs to be part of a larger conversation about substance use disorders and substance misuse. Because again, I wasn't just using one thing, I was using a lot of things. And so I think that's important. It's so critical for me to know what's going on in my community, know what laws are changing, like where I can direct my students to get naloxone. I've had students actually need to use their naloxone that they got through drug court. Fortunately, they weren't the one, they didn't need to use it on themselves, but someone called them and was like, hey, I need your naloxone, can you meet me? What a great thing that student was able to help someone else out and help save a life. So they are being used, and although hopefully I will never have to use it, I want to be equipped to know how to use it and what it is. I want my students to know, because I hang out with a lot of people in recovery, and relapse does happen. And the thing with heroin especially is that after a period of abstinence, whether we're leaving treatment or maybe we've been in a collegiate recovery program, our tolerance has gone way down. And so a lot of folks, when if they do relapse, they sometimes use the same amount that they were before they entered recovery. And that's when an overdose, and a lot of times a fatal overdose, occurs. So it's really important that folks know about naloxone, they know about the Good Samaritan laws that are in your state, so that, if this does happen, they know that it's okay to call 911 or where they can get naloxone, because that's when a lot of times this happens. Or if you get, now they're cutting it with elephant tranquilizers. I'm just like, thank God I got sober when I did, because I don't know that I'd make it very long in what's going on currently. So again, I think my big thing is that we need to be providing recovery supports on our campus for these students, and making sure that they're connected out in the community as well, because at some point, hopefully, you're going to graduate. If I've done my job well, we're going to retain you in school, you're going to progress, and you're going to graduate, and then you're going to need to be connected out into the community. So we build this campus community, we link them out with the local community wherever they're going next, to make sure that they have that ongoing support in this full college experience. And work collaboratively with our other efforts going on campus to address substance misuse, prescription drug misuse, to always have recovery be a part of the conversation, and an option. We talk a lot about raising the visibility of recovery, so that folks know, hey, this is an option, or there is help available, or maybe if I go tell Sarah what's going on, like that I'm not going to then be kicked out or grounded or whatever they think is going to happen, that I can be honest with someone for the first time in a long time and tell them what's going on. And so I'm really excited that we were having, this discussion, because it's so important, and I think the things that make us a little bit uncomfortable and that seem a little scary or taboo or, not appropriate to talk about are the absolute things we need to be talking about.
Thanks, Sarah. I've said I've been here a long time. I've said this to you before, but what Sarah and Ahmed and Connie and Dr. J have done to move the culture of recovery on this campus in a short period of time is incredible. I've been around here long enough to see that things don't happen that fast. So I just really hats off to you. Okay, so we're going to now take the rest of our time to hear from you and get some Q&A and what comments you might have. I've got some questions that have been texted. Kristen is over here with a mic, and if you want to ask your question live, she'll bring the mic to you. So what I'll do is I'll start off with one of these questions. If you'll hold your hand up if you want to ask something live, Kristen will find you. So the first question I have is, and I think maybe Sarah, maybe Kathy, whoever wants to weigh in. Do you find more students coming to campus with opioid addiction, or are they first exposed on campus?
I don't know that I can answer all of that. I know with the students that have been members of our collegiate recovery program, a lot of them are coming back to school. So they had taken some time off, they're coming back. And not all of them were here when they first started college. So we have a lot of transfer students. So I wouldn't say that they're all, being exposed to heroin for the first time on campus or anything like that. A lot of us, we also collect data on when did you start using all the different drugs in 13, 14, 15. So I don't know if that totally answers the question, but a lot of our students are transfer students. They've taken some time off and are coming back. So that's what we're seeing of students in our program.
One of the things that we know from the National Survey on Drug Use and Health is that the average age where the misuse of these substances starts is around 21 or 22. So there's no doubt that there are students probably coming with a dependency, but there are first uses on campus. We know this because we have that age of student. Anybody else want to comment about that question?
I don't really have any information that way. We rarely actually see students walk in the door and say, I've been using heroin. That's happened to me twice, and I've been here 3 years. And they started with prescription drugs long before they were here on campus.
Question?
Yeah, I am very interested in more of the history of what you were talking about, Sam, this morning. And I am from Rutgers, and I am the director of the drug and alcohol program there. And we have had an integrated health and counseling service for a number of years now. And I remember in the early 2000s, I was part of the leadership group of the health service. And JACO announced that we now had to ask every patient about their pain. And I remember like hitting the roof as a person who knows a lot about addiction, saying we have a healthy population on our college campus, fairly healthy. Why are we having to open that door and ask about pain? And I just, I'm not a conspiracy theorist, but in light of what's happened, I just kind of wanted to hear your thoughts, since we have two people here who might be able to address that.
Yeah, that's a great question. It seems to me that conspiracy theory doesn't really get to the insidiousness of what's going on here. And that is that a lot of, as one guy I quoted in the book said, a lot of people acting on what they think they knew was right, and was also in their economic or professional interest from a variety of paths, and it all didn't turn out very well. And I can't remember who said it, maybe it's Mark Twain. It's not what you, God, what was it? It was not, I'm going to butcher this. It's not what you think you know, it's what you think you know, and it's just not true, that is really a problem. And that is probably the theme. Someone else is going to look that up online somewhere and find the real quote. That's not what it is. My apologies to Mark Twain. But it was like, that was kind of the idea that seemed to me like, everybody had their own financial or professional interests, whatever it happened to be. The importance of marketing by pharmaceutical companies, I think, is crucial, is fundamental in all this. But also, their use of the pain specialists. I didn't go into as much as I could have about the pain specialists, but it seems to me that they are like the independent voices. They look to be independent, who are then given the megaphone of the pharmaceutical companies and their money They never would have had the voice they had it not been for that. But the pharmaceutical companies gained something extraordinarily important from those guys, and that was what people who looked to be independent, autonomous researchers who were just interested in evidence and knowledge and science. And if you can use that, that convinces, because the population you're trying to convince are doctors who really would be attuned to that. That is an important part of the story that I don't think should be overlooked or minimized. It's really important, their role in this. The pharmaceutical companies alone, I don't believe would be able to do what they did, even with all their money. It just, you need what's perceived as an independent scientific voice. And a lot of those guys are in fast retreat. Russell Portnoy, for example, who was one of the leaders, Dr. Russell Portnoy, who I take to be a sincere person. I don't believe he's a money-grubbing kind of like snidely whiplash. This is people who thought it was in their, they thought they were doing the right thing, and then were imbued with this kind of fervor, revolutionary, religious crusade type fervor to go after it and push it. He's backed off completely. I don't think he does interviews anymore, that guy. He wouldn't talk to me, so. But yeah, I mean, to me it feels like, but this is how life works. I learned this as a reporter. I got into reporting and I became far more independent minded as I did. I began to realize everyone does what they think is the right thing. You can't find anyone who says, yeah, I'm a scoundrel, I'm just this evil person who just likes hurting people. That's not human. It's everyone, and that's why the story is more complex. And that's why I rebel against, at the end, saying how we've got too many of these sexy solutions out there. The sexy solutions feel good. They're like heroin. They feel good and they end and they leave you wanting, and they don't do it for you, and they leave you wanting more, and we've done enough of that in this country, it seems to me.
So if you, do you want to add to that?
I'll just add that those of you who are 60-ish, remember when nobody really asked you if you were in pain or not, and then they came up with the faces, and they came up with all this kind of stuff. And in student health, we're dealing generally with a very healthy population, but how many of them will say that whatever their medical issue is at least a 7, 8, if not maybe an 11, is their pain. And I think most of these kids have maybe not really had pain. It goes back to what Sam said too about if they have a headache, it's got to be at least a 10. It was awful. It was,
no comparison.
No comparison.
Yeah.
Like, have you ever had a baby or kidney stones? and the other thing is, pain specialty used to mean a collaborative practice, like before 1990 or so. When you sent somebody to a pain specialist, they talk to you about, first of all, a realistic expectation about pain, that you're not going to be pain-free, but we're going to make it hopefully to where you can do your activities of daily living with minimal amount of pain. Physical therapy was always a hallmark. Cognitive therapy, behavior modification, acupuncture, maybe massage, maybe injections, maybe, all kinds of stuff. And it's getting back to that way.
Right.
But then when insurance companies, and Sam addresses this in his book, it's much more expensive to do that. If you can hand somebody, and actually, as a family practitioner, it's a lot easier just to hand them a prescription.
Right. That was the whole thing.
Yeah. It's easier to hand them a prescription. I was told that was the right thing to do, so there you go. Problem solved. And then I can see the next, how many patients of the day. So we're swinging back.
But one of the other things I think is interesting what you're saying, Doc, is that we as American pain patients didn't want to participate in that complicated strategy that you're discussing. We wanted something easy. It was like this, we felt we were entitled to a life without pain. The pill was a bam, it was a quick blast, That was what was fascinating about this. I come at this from a crime reporter standpoint. I knew none of this stuff when I started the book. I had no idea about any of this. But it came to me to be a story about how we as Americans began to prize comfort and easiness. Like we didn't want to participate in the wellness stuff. That kind of stuff is too hard. It's too hard to quit smoking. It's too hard to walk every day. It's too hard to, on and on.
I agree.
So we've described a perfect storm here around, factors that are contributing to this. There's no one single thing. There's a cascade of events. So again, raise your hand and Kristen will find you if you want to ask a question. I'll go to our text questions next. Steve, I think I want to start with you here. This is a difficult one. Very contemporary social issue. Two related questions all work together. What do you find with regard to race in the heroin epidemic? Maybe Sam can tell us what he thinks there as well. How does the relationship between police and communities of color affect law enforcement and recovery? Do you want to start with that, Steve? Or?
Do you want to give the stats on the color part? Because I can do the community piece.
It's a complicated question. I would say this is almost entirely a white problem. Okay, I didn't meet one non-white addict in my time, and I'm sure there are others out there, but I was stunned by how uniracial this issue is. There's a very long talk to go into about why that is. I think that there are a lot of factors that combine to make it so. I think the white population is the most economically privileged, the most, but also, this affects Appalachia too. So it's not, the economic issue doesn't seem to me to be the fundamental one here. I think in the Black and Latino communities, I'm speaking very clearly about the Latino community in LA. I had a horrible problem with heroin in the 70s. It was searing for that community, and the term tecato is a term that means like street junkie and has that same disparaging feel to it. So there is certainly, like almost every gang member in the 1970s in Latino street gangs were tecatos, were junkies, and they all those guys they all went to prison, and there's a deep kind of not that there's no drug problems in the Latino community. Meth is a very big deal, but there's this kind of like revulsion against heroin and that kind of thing. So I think that's part of it. There is a thing ventured that doctors were less likely to prescribe opiate painkillers to blacks and Latinos because they feared diversion, which is ironic because they prescribed them to whites, and of course that was just massive diversion. But that also doesn't explain fully the full reason for why it is so uniracial. The truth is, I don't think I know the answer to this. I think part of the question was, has the response been different? Is that part of the question? I thought that was part of the question.
Part of the question was, has a police community had a bearing on this in terms of how, in terms of recovery as well as the drug use?
I would say that there has been a couple of things that work here. There has been a far greater shift in how to treat this, in the approach that you need to use on the part of everybody, not just cops, but every prosecutors, the community, everybody, that this is now an issue that you need to provide treatment for. And there have been people who have suggested, well, this is because it's all white people being affected. And there's really some truth to that. This is the first time large communities of white people have been affected in this way, particularly these specific communities, rural communities, suburban communities. They just aren't prepared, and this is the first time they know an addict. They know their consciousness has been raised in to a certain degree. Like, oh, now I know that kid. He was the quarterback on my son's football team. He's a good kid, so he was not a criminal. So we need to treat this. The attitude is far more. People are far more willing to address this as a treatment issue. I would say that, and people compare it to the crack and the draconian prison laws that were imposed during and after the crack epidemic in the 80s and 90s. There is, however, also another very, very big difference in this one, and I alluded to a little bit in the talk, and that is, this is a silent, private epidemic. I covered crack. My first job was as a crime reporter covering Stockton, California, and where crack was just overwhelming the town. And crack was entirely public. It was crack houses, it was drive-by shootings, it was phalanxes of crack dealers, it was carjackings, a crime that was basically invented by crack gangs. It was huge increases in the crime rate. None of that is true with this. This is all private, quiet. It's parents, even parents, when I was writing my book, I thought, this book, when it comes out, will die. Why? Because parents are terrified of talking about it. They did not want to tell the story. They wanted to keep it private. So this one guy tells me, all across America, there are tens of thousands, hundreds of thousands of parents who are crying themselves to sleep each night, their hands around the photo album, terrified that their neighbors will figure out how their kid really died. And so there is no public violence associated, for the most part, no public violence associated with this. And that also has been why people have been far more willing to use treatment as the approach. If this epidemic had been associated with the type of crime that crack was associated with crack, I don't think you would be seeing nearly as much focus on, well, we need to treat this as a disease. It would be far more, get these guys prosecuted, get them off the street, deal with it that way. So it's a complicated story, I think, that accompanies this, but it has to do with, yes, race. Certainly a lot of white people are finally having to deal with this in their own family, and also the nature of the epidemic too.
So I would add to that, first of all, whether or not the opioid use is more slanted towards white, we know that all of the rest of the drugs on the spectrum and alcohol are equal opportunity destroyers. So we know that. I think the additional piece to add is there's at least some literature that says that there are cultural differences. African Americans, for instance, at least in some studies, have been shown to be much less likely to seek treatment. And in fact, keep it much more private. Right. So I think that there's that piece. But I want to actually circle back to the police and public safety component as well, because I think what we're seeing now post-Ferguson is a very important emphasis on the relationship between the police and the rest of the community. And it's not good. We know that from the viewpoints of many students of color. They're the ones on our campus. We're the most diverse of all of the Ohio State campuses. Almost 20% of our incoming freshmen are students of color. And so we see the need to really handle issues between our local police forces. And actually it's even more complex for us because while we're in Mansfield, we also abut the city of Ontario. And so half of our housing is in Mansfield and half of our housing is in Ontario. And so we're dealing with two police chiefs and two police forces. And so it's extraordinarily complex. Again, from a prevention standpoint, we've learned it's very important to get those public safety officials in front of our students from the get-go. Getting to meet them, getting to understand their ways of operating, what they're looking for goes a long way toward, I think, building those bridges. And I think that's the key, again, is to be proactive in building those bridges.
Thank you. Again, raise your hand if you want Kristen to come to you with a mic, if you'd like to interject you as soon as that happens. Ariele, I asked a series of questions here about naloxone and harm reduction, and maybe I'll start with you. Others may want to weigh in. In instances where naloxone has been employed at the universities, what kind of protocols do you see? Is there a need for 24/7 healthcare staffing if we're going to be providing naloxone? And then the third part is other kinds of harm reducing strategies like needle exchange. So you want to start us on that one?
Sure.
So what kind of protocols, what kind of healthcare coverage, health service coverage do we need, and what about needle exchange?
Needle exchange on campus in general?
Yes.
Or maybe, okay.
I think in general, but we'll put it down to the college campus.
Sure. So I think that what we're seeing is it's relatively new for schools to grapple with these policies.
We just a little while ago brought together some experts in this space from the Harm Reduction Coalition in New York, and there's another, I think in North Carolina that came up, and some other emergency physicians and people that just have a lot of experience seeing where there are opportunities for intervention that we're not using, both on campus and off, to talk about some of these same things. As I mentioned earlier, it seems that most campuses are resorting first to their campus security in terms of what I've seen anyway, to house naloxone. I do absolutely think that there needs to be policy and infrastructure in place that extends beyond naloxone and substance abuse treatment and intervention on campus. When we talk to schools about all kinds of health issues, what we hear from faculty all the time is that, outside of clinical settings, professors, other people that interact with students, they feel empowered to act when they know that there is a system in place where they know exactly what to do next, that it's not just that they're gonna have this problem on their own and they don't know who to turn to and it becomes bigger than it is, and I'm just here to teach math, not do these other things. We hear a lot of times from faculty that there needs to be really comprehensive policy in place. So we work with schools not to direct that process, but to really just help them figure out what it is and how they can implement it. In terms of there needing to be 24-hour coverage, that's an interesting question. We talk with a lot of schools about having RAs have naloxone and having that in the dorm. I think that's a great idea. A lot of schools think it's a great idea. It just still is, on a lot of campuses, too controversial, unfortunately, to begin there. So while that's not ideal, we still feel like it's great progress for a school that maybe a couple years ago wouldn't have even had this conversation to say, okay, we're listening, we'll start with campus security. And then if it begins with campus security and they also take the advice of forming this interdisciplinary team and really connecting all these different players on campus, where we can create a space where campus security is talking to the president, that's talking to athletics, to Greek life, to whoever is important on your campus, then maybe we can help grow that culture and change the way that naloxone is on campus. So I'll say that. In terms of needle exchange, I think that would be, I just can't see that right now. Not because I don't think it's a good idea. I come from actually a background of syringe exchange. Prior to the foundation, I was doing research. I live in Manhattan and Washington Heights. I don't know if any of you are familiar. We have the Washington Corner Project up there. And I did some research there around active injection drug users and establishing a model of care in the medical community around treatment for hepatitis C. And so I'm personally a big believer in syringe exchange. I think it is even more controversial and hard to swallow than naloxone. So, yeah.
Thank you, excellent, appreciate it. Do we have a live question, Kristen?
Hi, I'm Christina, and I want to preface my question by also saying that I'm also a person in long-term recovery, which means I haven't had to put a drug or alcohol in my system since February 11th, 2005. I'm also a person in long-term recovery who lives with another incurable, very often painful disease called Crohn's disease. And what my question has to do with is how, as professionals, do we help keep the pendulum from swinging all the way back in the other way? Because I can tell you that when I try to advocate for myself as a person in recovery who often deals with chronic pain, I experience a lot of prejudice. I've had to switch doctors, and I've been kicked out of ERs for being accused of drug seeking, and I'm like, I don't want your drugs, I just want to make sure my intestines aren't about to explode. And I'm hearing that from a lot of people in the recovery community now, is that they're experiencing a lot of prejudice, and doctors are even more afraid to treat for legitimate chronic pain. So how, as we as professionals, how can we help keep that pendulum from swinging back in the other way? Because what I don't want to see is addicts turning back to the streets to self-medicate because they're not being treated adequately.
Excellent question, thank you.
That's a difficult tightrope as a patient and also as a physician. I think the way you express yourself and verbalize your concerns and advocate for yourself is extremely important. I think it's going to take a while for the dust to settle, so to speak. You know, within the last month, everyone in the state of Ohio who's licensed to practice medicine had to take a computerized course about the use of opiates, you know, as part of Governor Kasich's ongoing efforts to try to get people to prescribe fewer opiates, which is a good thing. But you know, it's now a kind of a constant barrage of completely opposite messages, it's a crapshoot, frankly, who you might end up with in the emergency room. You might end up with a doctor who's very familiar with recovery and who might feel comfortable with a very small number of a reasonable dose of medication to help you with your pain. Then there are going to be other people who are not familiar. They're just going to say, uh-oh, can't do anything for you. You know, you're just this and you're just that, and a lot of labels and whatever. It's very difficult, and I think it is a concern that the pendulum will swing the other way. I think, unfortunately, we have a lot of people too who have become disabled with the opiates that we prescribed for 20 years, and are disabled and are on pensions and whatnot, and to try to make them get up and get moving and all this kind of stuff is maybe a little bit unrealistic. So we have a real mess to kind of clean up and to sort out so that we can continue to treat people in a reasonable way, you know, and help them with their pain.
So if I could ask, we've got like a handful of other questions, and maybe take another minute, Kathy, and questions are more about, you know, what about long-term use of Suboxone? You see issues there. What about there are a lot of pharmacy students sitting here. They're asking, you know, how could pharmacists get involved in this issue better? Any follow-up around Suboxone or just other things medical providers, maybe pharmacists could do to help?
Well, first of all, I love pharmacists. Pharmacists are my best friends. They keep me out of trouble, and they do a lot of, you know, they see stuff a lot of times that we as providers do not see. Networking in the pharmacy themselves or out in the parking lot or whatever. I mean, I have gotten phone calls from pharmacists who say, you know, it might not be a bad idea to take a look at this. Huge help. So I think just keeping your eyes open and trying to, and I know maybe not all providers are as open to those phone calls from pharmacists, but I think it's terribly important. Other than that, I'm not sure. I mean, you know, you see patterns of behavior and prescriptions, and with our ORS system, the Ohio automatic reporting system that prescribers and pharmacists use, another great tool. To Suboxone is not the best answer, and I totally admit that. I have experienced more with Suboxone in Springfield, Ohio, where I worked for a drug and alcohol rehabilitation facility, and many of the people there were lifelong, long-term heroin users. Suboxone gave them their life back, and some of those people will probably never get off Suboxone. But they can attend their family birthday party without causing a ruckus, or they might be able to buy gifts for a friend, you know, for a birthday, I mean, and have a decent relationship with their landlord. I mean, but they will always be needing Suboxone maybe to have a relatively normal life. These students, and there again, we don't have any experience really on this campus yet with us at the Student Health Center treating with Suboxone. However, my expectation is that these are basically young, healthy, bright people, otherwise they wouldn't be here to start with. They have already sought out recovery at a young age and hopefully don't have too many messes to clean up. I am hoping that Suboxone would be a relatively short-term maintenance. And by that, I mean, we know that coming right out of rehab and tapering off of it in 4 to 6 weeks does not work. So those people who choose to use Suboxone may need to be on it for a couple of years. My experience is when people feel ready, they have put the pieces back together of their life. I mean, it's going to take a good year for your brain chemistry to kind of get back to normal. We try to take care of other comorbid situations. Are they bipolar? Do they have legal issues they got to clean up? What's the relationship with their family? Can we help them in many other ways to put together their life again, so that then when we taper them off of Suboxone, because it's hard. It's really hard to come off of Suboxone. And it's a joke to think that it's not. It's never as hard as it is to come off of heroin, though. So as you slowly, slowly taper them off of Suboxone, they've got to have all those other pieces in place, or it's not going to go well. And we can always help them with other doctors. We can always help them with other drugs. I mean, like there's clonidine to help them with the goose flesh feeling. There's ibuprofen to help with the aching that you have. There's something we can give you for nausea. So there are other ways to control some of the withdrawal symptoms as you come down off of Suboxone. But if you come down off of it slowly, there really shouldn't be any problem. I tell them, you're going to be uncomfortable. It's life.
That's it.
You're going to be a little achy. You're going to be uncomfortable. It will not last forever. But they do a lot better with their community of recovered people around them.
So we're just about out of time. I didn't get to all your questions, I'm sorry. I tried to patch them together as best I could. Sam, I got about 1 minute. I'm going to give you one more question.
Okay.
First of all, 2 people are asking things. First of all, thank you for the book.
Thank you.
And should there be a Dreamland 2? This problem keeps morphing. And what's your next project?
Well, first of all, thank you, Ken, for spearheading this whole thing and getting this done. Many months we've been talking about this, and I really appreciate it. Also, thank you to Sarah for talking to some reporter guy from out of town who she didn't know, who just showed up and started talking about this stuff, and I appreciate all the help you gave me. It was very kind of you. There probably should be some kind of follow-up to this. I don't think I'm the guy to write it. I could tell you that 2 years ago, when I put this book out, my wife and I thought, oh well, this book's going to die, as I said earlier. We're going to quickly go on to something else because no one really cares about this topic in America, apparently. Like, literally, that's what we were thinking. And I am extraordinarily happy to see that now that's not the case. Everybody's tripping over each other now to write about this all the time. And I think in some newspapers, in fact, they have full-time beats. That's great. That's so great. That's wonderful. But I also think that kind of, I'm looking for other projects, basically. I may touch on some of the topics eventually in another book about a community, the destruction of economic base for communities in America. I think that's for me probably the place. I started this as a layman. I remain a layman. I'm not an addiction specialist or a doctor or anything like that. And so the topic of that related to Dreamland as the crushing of community and the rebuilding of community is going to be a topic I'm very interested in. However, my next project, I backed into this project, this book, this story. Didn't know what Vicodin was or OxyContin was when I started in 2009. I started this because I wanted to understand why heroin traffickers, particularly heroin traffickers from one town, were doing such banner business. I thought no one used heroin anymore. I didn't know why, and I didn't know why they would be using heroin in West Virginia, for God's sakes, or in Ohio or in Indiana, right? And so I continue to be interested in the issues of immigration, Mexican drug trafficking, a variety of things like that. And so my next project is which I've already started, I've been spending a lot of time in Tijuana lately, is about that topic, all connected to the life story, the biography of a legendary, now murdered many years ago, but a legendary narco singer from Mexico who lived in Los Angeles area. And so that's probably my next project. Again, I'm hoping to weave together there's a lot of tales here to tell, and I love the stories that you can like write about 5 stories in one, and that's kind of what I'm going to do.
Sam, thank you for being here, Kathy.
Pleasure. Thank you all.
And Arielle and Sarah, it's been a real pleasure. Thank you very much.
Thank you so much to our panelists and to Ken for moderating, and to Sam. Wow, it was really inspirational and gave us a great look at the history of kind of how we got to where we are right now. So thank you. We do have just a few announcements, so I'm asking you to hang tight. I know we're just running a little bit behind schedule, but there was so much to cram in. We want to again thank our sponsors for the conference, particularly Cardinal Health, for helping bring Sam to the conference. And remind you to visit our exhibitors. You have your exhibitor passports, and if you can get to all of them by the end of the conference today, that puts you in a drawing for 1 year of Screen U, your choice of the program, alcohol, prescription drugs, or marijuana. In your folders, there's evaluations, and so we encourage you to complete that evaluation. You can either leave it on your chair if you get a chance to do it before you leave, or you're welcome to turn them in at your next session. So take those evaluations with you and please complete them. In addition, if you need continuing education hours, I just want to remind you that we do need your signature that you signed in for the conference again today. So that's a requirement from the boards that we receive the CEUs from. It gives you your hours for these plenary sessions.
This is really good.
So if you need continuing ed, please stop down sometime today to the lobby and sign in. If you do not need continuing ed, you do not need your signature again. We have a snack break today at 2:30, again here in the Blackwell, so I encourage you to come back here. That's another time to go visit those exhibitors.